neoadjuvant therapy, endocrine, cytotoxic, and biological therapies from looking at breast cancer.
Sorry. Yeah, okay, thank you. First of all, I would like to thank the organizers for having invited me. I have two talks, one on locally advanced breast cancer, the other one on neoadjuvant therapy of operable disease. I decided to make a mixed up because there is a lot of overlapping between the two topics. So in the first part, I will talk about chemotherapy and inflammatory breast cancer and endocrine therapy. And in the second part, I put together, which is in the next session, I put together the targeted therapies and some issues on the neoadjuvant use in operable breast cancer. So to start with, for whom is indicated neoadjuvant therapy? Stage 3, including, of course, inflammatory. Any patient who could clearly profit, which are, of course, triple negative and HER2+, and if mastectomy is the only option at presentation based upon tumor and breast size relationship. So this is the aim of neoadjuvant, to shrink the tumor and to make it operable from mastectomy to lumpectomy. You need sometimes at least 4 months to reach this goal, and sometimes you don't even reach this goal. So one of the most important things, and Professor Viale will talk about that, is pathological complete response. This is one way to measure the efficacy, the long-term efficacy of neoadjuvant treatment, and you have different definitions of pathological complete remission, which is the first one, which was used in the NSABP trials, is no invasive cancer in breast. The one who has been used in the memorial experience is no invasive cancer in breast and nodes, and the more stringent definition, which is one used more and more in the present day, is no cancer, invasive or in situ, both in breast or nodes. Which is the likelihood of obtaining pathological complete remission in breast cancer? And of course, you have a higher likelihood in younger patients, in tumor of less than 2 centimeters, ductal histology, lobular carcinoma do not respond well to preoperative therapy, high grade, high proliferation rate, ER negative, triple negative, and basal-like or HER2 positive tumors. And vice versa, if you don't have these characteristics, you have a lower, even a very low likelihood to obtain a PCR. Why is PCR important? Because it can have an impact on long-term outcome. These are data published very recently by Gunther von Minkwitz, who is the head of the German breast group, which conducted lots of studies in neoadjuvant breast cancer, and they looked at 4,000 breast cancer patients. And is this working? Apparently not. Yeah. And 4,190 patients receiving neoadjuvant, the standard anthracycline and taxane-based chemotherapy in 7 randomized trials. And you can see that having a pathological complete remission in luminal A does not impact your survival. And this is progression-free survival. but it's impacting your survival if you are HER2 plus or triple negative. So if you don't achieve a pathologic complete remission, you have a very, very bad prognosis. Then you have mixed data in Lumino B, and these are patients who received, if HER2 positive, they received trastuzumab as part of their treatment. If you are Lumino B, HER2 plus, despite HER2 negative, you have a very bad prognosis, which is almost the same of triple negative if you don't achieve a pathological complete remission. If you are a Lumino B but you receive HER2 treatment because you are too positive, it doesn't matter. So we don't really understand why Lumino B HER2 negative have such a wide prognosis, but it's clear that in Luminal A, maybe pathological complete remission is not the end point of your treatment. So let's start for ER unselected disease. So when you treat with neoadjuvant treatment women who have either ER positive or ER negative disease. I will show just a few data. This is one of the German trials, the famous GEPAR trio trial. These were 2,000 patients. Low-risk patients were excluded, and this is the definition, and they had two different populations. So they randomized patients who were no change after 2 cycles of anthracycline and taxane-based. In the non-responders, so they had stable disease as measured by ultrasound. You can guess if ultrasound is the best method to measure response, but they defined patients who were not responded, which were 30%, and they tried to change the chemotherapy. So they randomized to receive 4 additional cycles of TAC or to switch to navalbine and capecitabine. In responding patients, the question was, is it worthwhile to give these patients a longer treatment? So they were randomized to have 4 additional cycles to end with a total amount of 6 or to 8. And as you can see here, and these are the responder, if you extend the treatment duration, there is no benefit in terms of pathological complete remission, but of course you add toxicity, which is quite consistent for the TAC regimen. If you are a non-responder, is not worthwhile to switch to, you have the same results if you keep going with the same regimen or if you cross over to a non-cross resistant regimen. And this is the same for the breast conserving rate. So if you add 2 additional cycles in responder, you don't add any additional benefit in terms of breast conserving, and if you switch to another regimen, of course, you don't add anything. And in this population, the change to navalbine and Xeloda was, of course, better tolerated than the Tax4/6. So this could be a reason to switch to a less toxic regimen in patients who did not tolerate taxane and anthracycline, but there is no additional benefit. This is the GEPAR-Quinto trial in HER2 negative breast cancer, and the question here was, is there any benefit in adding bevacizumab to EC? And then we don't have the results of the addition of switching to everolimus. These were almost 2,000 patients. 88% of these patients were anyway operable at diagnosis, and the primary endpoint was a very strict definition of pathological complete remission. No invasive disease in the breast and nodes. Which are the results? There is no significantly different in if you add bevacizumab to a combination of anthracyclines and taxane, but you add significant toxicity, so it's not worthwhile, and it's very expensive. there is an advantage. So this is the overall population. But if you look at the subset of patients with triple-negative disease, there is a substantial difference, which is significant in PCR. And this is shown in this population, in this slide as well. The only significant effect is in the triple-negative population. This is a similar trial from a175b comparing taxane anthracycline plus or minus antimetabolites and plus or minus bevacizumab. So this trial had two different questions. It's better to use instead of to add to taxane capecitabine or gemcitabine plus or minus bevacizumab. And once again, there is no additional benefit if you change and you add more than you change. If you add capecitabine or gemcitabine to a conventional regimen, and there is a slight benefit which is significant in adding bevacizumab, but if you look at the population, in contrary with the previous study, the benefit is apparently in ER-positive women. So this is in contradiction with the previous result and is in contradiction with biology because bevacizumab as anti-angiogenic should work better in highly proliferating tumors. So the conclusion is that, once again, you don't need to add additional drugs to improve outcome, and the role of bevacizumab is not adding any benefit to your patients. And so this is the comparison of the two trials. As you can see here, in triple-negative, in the Gepard-Quinto, you have a significant, the bottom line, you have a significant benefit, and the opposite is true in the North American trial. And there was some differences in the duration of bevacizumab, because in the Gepard-Quinto trial it was given till the end of treatment. In the American trial it was a shorter duration. You can see the discontinuation rate, which is not very high. Of course, bevacizumab is associated with significant toxicity. So, triple-negative disease. There is no trial so far which is dedicated to triple-negative patients. We have subset analysis in this population, but so far, of course, they are a very smaller population, and so far no trial was conducted in triple-negative patients. There are some trials ongoing with PARP inhibitors, with others, taxane, with sunitinib, so anti-angiogenetic trials. And so there are a few trials dedicated to triple-negative population, because of course they are a different subset of patients that should be studied separately. What about inflammatory breast cancer? It's a different disease. It's very difficult to diagnose, especially in young patients, because sometimes it's, of course, is not recognized as a neoplastic disease. And as we all know, the outcome of inflammatory breast cancer is much worse than the general breast cancer population, but there is still a difference, because if you have ER-positive inflammatory breast cancer, your prognosis is significantly better than if you are endocrine unresponsive, which is quite clear. This is a series from the MD Anderson. It's a huge series of inflammatory breast patients, 316, collected through the late 80s to the end of the 2008. And all these patients received trastuzumab from 1999 if they were HER2 positive. And you can see once again that if you are ER positive and HER2 positive and you receive trastuzumab, your outcome is quite good, as well as you are ER plus, despite having inflammatory breast cancer. And your prognosis is very, very poor, 30% alive, if you are ER triple negative or 2 positive, despite receiving trastuzumab. So there are not specific, very few trials dedicated to inflammatory breast cancer. This is a SWOG trial which stratified for inflammatory breast cancer 116 patients. Fortunately, this is quite a rare subset. And the question here was very interesting. So a standard regimen with anthracycline and taxane compared to continuous treatment. So weekly anthracycline plus oral cyclophosphamide, and the duration was equivalent in the 2 arms. And in general, you can see that continuous treatment is not better in the general population than non-continuous, apart from inflammatory breast cancer, where there is a significant difference in PCR rate, breast and node, in inflammatory breast cancer. So apparently, continuous treatment is worthwhile in this population. But when you go to disease-free, you have a not significant difference in favor of the non-continuous arm in the inflammatory breast cancer. And as you can see, the disease-free is poorer than in the normal, in brackets, locally advanced breast cancer. This is one of the very few trials which was conducted by the company in inflammatory breast cancer, HER2 positive, 50 women. They received initially lapatinib monotherapy, and then they added paclitaxel. And as you can see, nothing extraordinary. The response rate was quite high and not difference in the HER2 positive and HER2 negative. The clinical response to lapatinib monotherapy was 30% in the HER2 inflammatory, which is in the range of what we know, but very few pathological complete remission, 17%, and none in the HER2 negative subgroup. What about endocrine responsive disease? One of the questions is, should I give chemotherapy in these patients? This is a trial, not a huge one, but 2,040 women randomized to chemotherapy, a standard anthracycline taxane based, versus endocrine responsive, 2 arms, 2 very common aromatase inhibitor. And as you can see, not only clinical, also mammographic, but PCR is very low, but there is no advantages to give these women chemotherapy. So you have the same results just with endocrine treatment. So it's quite reasonable to give to postmenopausal women with hormone receptor positive disease. We have no data in premenopausal women. So endocrine preoperative treatment in premenopausal women should not be given outside of a clinical trial. Things are different. We have the data in postmenopausal women, and so the responses are good, and they allow superior rates of breast conserving surgery. And they apparently are better than chemotherapy and less toxic. So you could give these women only endocrine treatment. Which are the data? We have 3 major trials. This is the English trial, the PO24, which randomized tamoxifen versus letrozole for 4 months, 337 women. And the data is that letrozole is significantly better overall in clinical response, ultrasound response, mammographic response, and breast conserving surgery. And if you look to the data, this difference is run by the HER2 positive population. There is no apparently significantly different in HER2 negative population, so there is no benefit in giving aromatase inhibitors as compared to tamoxifen, which is much cheaper in ER positive, HER2 negative women with locally advanced breast cancer. This is the IMPACT trial, which is the neoadjuvant part of the adjuvant trial, and randomized between anastrozole, tamoxifen, or the combination of the two for 3 months, a little bit shorter than the previous one, the same amount of women. And this is quite striking, because here you don't have any significant difference in clinical response, ultrasound response, and you have just a significant difference, but this is quite different to assess why they decided to go to breast cancer surgery in a different way. But women under anastrozole did better, underwent breast conserving surgery much more than women treated with tamoxifen. And in this trial, there is a difference, but it's not statistically significant based on ER status. The last trial is the PROACT trial, which is chaired by an Italian investigator. And here you have women, they could receive chemotherapy. This is different from the previous two trials. Once again, 450 patients, and they received tamoxifen or anastrozole for 3 months. And the comparison, the meta-analysis of these trials, overall, they were published and were reviewed by CHIA, they say that aromatase inhibitors are more effective than tamoxifen for breast cancer conservation. And these are the comparison between the trials, and you can see, as we said before, there are some differences, the duration, the possibility of having received chemotherapy or not, but overall the meta-analysis seems to suggest that aromatase inhibitors are slightly better. Well, once again, we are trying to have targeted therapy in all our patients, and if you have highly endocrine responsive women with ER plus HER2 negative disease, you can try with tamoxifen first, as we saw in the previous trial. Which is the best aromatase inhibitor? This is the ACOSOC trial, which compares the three of them, exemestane, letrozole, and anastrozole, and 377 patients, and you can see that there is no difference, there's no better aromatase inhibitors in this context, so you can use whatever you want. But now the way of measuring, exactly measuring and predicting response is under active consideration. This is one of the score in this example is in the endocrine responsive population, and Mike Ellis put together all these features, the diameter, the lymph node status, the Ki-67, great debate, and Professor Viale maybe touched this on the definition of what is Ki-67 low and high, and the intensity of ER staining, which is not so standard as well. And they put all together, and they developed this PEPI score, and they tested the PEPI score in the PO24 trial, and they state that both pathological tumor size, node status, Ki-67, and ER status are all independently associated with relapse-free survival and breast cancer-specific survival. And so they urge the prospective validation of this score in clinical trials, because this, of course, was a retrospective analysis. So new compounds, very briefly, and we had a lot of publicity and promotion of everolimus all over the place. Which are the data with everolimus? This is a trial published by José Baselka, and the comparison of letrozole and letrozole plus everolimus. Which are the data? 270 patients. The aim of the trial, the endpoint of the trial was palpation, which is, in my opinion, not a very sound objective, because it's very subjective. But they measured and they compared ultrasound, and as you can see, there is a clear difference in favor of the addition of Afinitor, which I think it's a little bit too early to add this drug in routine clinical practice, because I think one trial is not enough, and I personally believe that everolimus is a very good drug when you have endocrine resistant, but I don't believe that upfront giving everybody everolimus is a good choice, and it's very expensive and it's quite toxic. So which are, to conclude, the open question? PCR is a valid surrogate of long-term survival and cure, but PCR rates range from 30 to 40% in ER and PGR negative tumors. Assessing ER and PGR negativity is not trivial to some extent, but is very poor in endocrine responsive tumors. But do we really need? We saw that PCR maybe is not the good marker for ER and PGR positive tumors. How could we improve PCR rates in the HER2 positive and ER negative population? We will see the data on the HER2 positive population in the next talk. Which are the conclusions? You need to run and to prescribe and to offer neoadjuvant treatment to your patients. You need an experienced and multidisciplinary team. This is essential. And it should be not only a clinical multidisciplinary team, but the best way is to have a research team behind you, because the neoadjuvant setting is the best way to test, and we will see that in the operable population, to test new drugs and new ideas. Then the optimal management of patients with residual disease, especially in triple negative and HER2 positive patients who do not achieve PCR, is a real challenge. They do behave very poor, and so we have to do research in this population. There is no evidence to support additional chemotherapy after surgery, whatever is the results of the surgery, to add adjuvant therapy if you gave an adequate preoperative chemotherapy. And novel agents and approaches are urgently needed. And then we miss reliable markers of response, for example, in the ER and PGR population. And so to try to understand why some patients who do not have PCR still have a very favorable